Hi Natalie, Natalie Allen from Sydney, Australia. You gave a fantastic talk on pain and Parkinson's disease. I just wonder if you could tell us a little bit about what we know about pain and PD and where your particular research interests are going in this area.
Yeah, okay, thanks Lynn. We actually don't know very much at all about pain in Parkinson's disease, which is why I'm starting to have a look at this area. So what we do know is that Parkinson's disease affects many more areas of the brain other than just the basal ganglia. And some of those areas of the brain that are affected by Parkinson's are also the same areas that are involved in processing and modulating pain signals. And it's really interesting because pain is actually very commonly reported by people with Parkinson's. So up to 85% of people with Parkinson's complain of pain symptoms. And after adjusting for osteoarticular comorbidities, chronic pain is actually twice as common in people with Parkinson's disease as in people without. So pain seems to be a really important problem that has had very little recognition amongst clinicians, both allied health and doctors alike. Having said that, when you do read pain papers written by neurologists, they do recommend exercise as one part of a pain management program for people with Parkinson's. So I've had a bit of a look at the literature to see what evidence there is that exercise might help in terms of managing pain in people with Parkinson's. And there's very little to guide us in this area at the moment. So there's a little bit of evidence around neurophysiology and laboratory-based studies that exercise might influence the parts of the brain that are involved in pain processing that are also affected by Parkinson's. But there is some potential there, and there's a little bit of a suggestion from a clinical trial that it might be beneficial to help improve pain over time, possibly, but we're really at the start of this journey and we need to start thinking about it.
So is this an area that you're thinking of taking forward in your own research?
Yeah. So what I'm actually planning a study for the second half of this year where I want to have a look and see whether or not people with Parkinson's disease actually have a normal exercise-induced analgesia response to exercise, and also start to explore a bit more some of the associations between physical activity, sleep and Parkinson's motor impairments and pain. We do know that rigidity is associated with pain with Parkinson's while tremor isn't, but we don't really know a lot about the nature of pain or the impact that pain's having on people.
That's great. Well, we'll watch this space with great interest. Thank you.
Thanks, Lee.
Colleen, you've just given a fantastic presentation at the symposium, Exercise is Effective as Medicine in Parkinson's. Your talk was on falls. Can you just summarise for us where the evidence is for falls? Where are we at now in Parkinson's, and where do you think we need to go in the future?
Well, I think we're at a good place, so that in the last couple of years we've shown that exercise can prevent falls in Parkinson's disease. We've shown it with a variety of exercise, so Tai Chi, progressive resistance strengthening exercises, and the use of movement strategies. But further to that, we've also shown that there is a difference in responsiveness to exercise according to level of risk. So in a recent trial that we've just published, we showed that people with low disease severity responded very well to minimally supervised exercise that targeted balance, strength and freezing of gait using cueing strategies. But we found with people with more severe disease severity that in fact there was a trend towards an increase in falls with exercise.
Tell us, what are the key learning points that physios that we need to know about preventing falls in Parkinson's?
So the key learning points are that we can prevent falls and we can particularly prevent falls in people with early disease. In addition, in people with early disease, we don't need fully supervised exercise programs. We can use more minimally supervised exercise programs, and these are also cost effective.
Excellent.
People with more severe disease, then we should be looking at more multifactorial approaches. So we should be considering strategies for reducing falls and for changing behaviour, environmental hazards reduction, as well as exercise probably in a more supervised capacity.
Fantastic. Thank you very much, Colleen. A wonderful talk. Thanks. Thanks, Gammon, for a fantastic talk in the symposium. So what I'd like to do is to ask you just to tell us very briefly, what's the benefit of group exercise? Why group exercise in Parkinson's disease? What are the advantages?
Group exercise is a great approach for people with Parkinson's disease and anyone in general, really, because it's a way to reach a lot of people at once, so it's very efficient and economical. But some of the specific aspects that are very important for people with PD are that group exercise engenders social support among the group and a sense of cohesion. The people are interacting with their peers who are dealing with the same types of things that they are, and that helps to contribute to those social support and cohesion aspects. And those things then feed into motivation, which is critical for adherence. So we find that when people with Parkinson's disease engage in group exercise, they're more likely and more motivated to adhere and continue to participate over the long term.
So I'd like to just, interrupting you, but I'd like you to tell me about, there seems to be a huge amount of evidence, a trend to increasing evidence for dance. So could you comment on that?
I think dance is a great intervention and a great form of group exercise because it is very engaging, not only for the person with Parkinson's disease, but also their care partner. That's something that many people indicate to us is a difference relative to other programs that they have the option to participate in, is that both the person with PD and the care partner are on equal footing and engaged in the activity. Another key aspect is that dance, it can be aerobic if done at sufficient intensity. It's inherently a multitasking type of activity, so it engages people cognitively as well as physically. And some of the moves inherent in dance are the very things that people with Parkinson's disease struggle with. So within the context of the dance, they have opportunities to get multiple trials of practice on the things that are difficult for them.
So you kill two birds with one stone. And do you think it's possible to modify symptom severity over the longer term using group intervention with dance?
I do think it's possible. We have data for as long as a 2-year period suggesting that people who danced over the course of 2 years had less severe motor signs than people who did not dance over that same period of time.
That's great. Thank you very much.
Thank you.
Hi Terry, thanks for a fantastic talk. What I'd like to ask you is if you could tell us very briefly, we all know that exercise, or we're hearing that exercise is beneficial, but the real problem is it's all very well telling people, but will they do it? What's the best way to facilitate people to adhere and continue exercising in PD, and is there any evidence?
Well, what we found in our cross-sectional studies in about 260 people with Parkinson's disease was that when we looked at, what are the key factors that distinguish exercisers from non-exercisers? And one would think that disease severity, limited mobility might be the key factors that prevent people from exercising, when in fact what we found was self-efficacy was one of the key factors. So what that tells us is that the mobility limitations of course play a role, but we've overlooked in the past or not really given a lot of weight to the importance of the behavioral factors. So so now what we know is self-efficacy seems to be related to whether people engage in exercise or not. But what we don't know right now is it modifiable in people with Parkinson's disease? It is modifiable in healthy older adults. It's been shown to be modifiable in people with MS, in people with arthritis, so in people with other chronic, disabilities. So we're hypothesizing that in fact it is something that's possibly modifiable. I mean, we're doing work right now in our exercise trial looking at various types of technology and mobile health technology to try to enhance self-efficacy, that being our target. So a behavioral change approach to really target self-efficacy to see if in fact we can get better long-term engagement and hence better outcomes.
That's great. So you're saying basically that if we can get people to feel better and more confident about themselves as exercisers, then we may stand a better chance of getting them to adhere.
And I think we also learned that outcome expectation was critical. And what we learned in talking with people with Parkinson's disease is that they simply didn't really realize the impact that exercise could have. And so how can you possibly sustain and engage in something that's so demanding if you're not very confident that it's going to make a big difference?
Okay.
And so one of the key things with your patients is to educate them about the importance of exercise, inform them about what the literature shows, talk to them about what your expectations are so that you align with them and their expectations, and then fire away.
That's great. Some very important messages there for us. Thank you. Hi Lee, thank you for a fantastic talk. So my question to you is, it's all very well to talk about strength and endurance training in people with Parkinson's disease, but let's face it, it's difficult. So what's the evidence to support it, and how are you going to persuade people to do it?
Okay. So if you think about the cardinal signs of Parkinson's disease, when you think about bradykinesia and hypokinesia, and then the functional difficulties that people have, things like getting up from sitting down, climbing stairs, moving slowly. At their core, they all have reduced force production as one of the potential reasons that people have difficulty with that. And I would argue that resistance training, in particular, provides a very unique and beneficial intervention for those individuals that has one of the more broad spectrum benefits for them. There's also evidence to suggest, even if you provide a very nominal level of resistance training stimulus in terms of dosage, that you can get some benefit. For example, there's a study in the Journal of the American Medical Association by Lee et al. That was primarily focused on a Tai Chi intervention and fall reduction. But if you look at the resistance training intervention, that was one of their control groups, they actually use 1% of the body weight as their resistance training stimulus, and those individuals actually gain some strength. If you use a more appropriate dosage, you get actually pretty robust responses. In addition, Parkinson's does not directly affect the cortical spinal system, so by doing resistance training with those individuals, there's nothing to suggest physiologically or neuromuscularly that they can't benefit from that.
So it's safe.
It is definitely safe. Thanks for asking. That one of the other reasons to do it is that there's not adverse events. When we've actually drawn blood from individuals, pre and post resistance training, we show a normal increase in serum creatine kinase that would be demonstrated by anybody, even without Parkinson's disease. And it does not go to a pathologic level. It does not damage the muscle.
Okay, that's great. So send your patients to the gym and get them lifting weights.
Yes,
Thank
so then
you.
they can have a beach body. Right?
Thank you very much.
Thank you.